Welcome to the Certification in Infection Prevention and Control training sessions. These are presented by APIC South Carolina Palmetto in partnership with South Carolina Department of Public Health. This is session 1. Welcome to your CIC journey. We want to thank you for joining us during these study sessions. We will review an average of 25 questions per session. The CIC Study Guide 6th edition will be used for chapter review questions. Some study tips as we proceed through each session. It would be beneficial to obtain a copy of the APIC CIC Study Guide 6th edition. The chapters correspond to the chapter questions we will review each session. Study the areas where you receive your lowest scores and then retake the practice questions or tests. There are 3 practice tests in the CIC Study Guide. Feel free to pause these video slides at any time so you can read the question and think about the rationale before we move on to the answer. The APIC text is where the CIC questions are derived. If you don't have access to the most recent text, you will need to get a paper copy or electronic access to the text online. The slides we present will give you the opportunity to experience CIC level questions and think them through thoroughly. It will help you keep you accountable. You don't have to prepare for the study sessions. Just listening and guessing will give you an idea of how the CIC questions are asked. Question 1. A patient was just admitted to a long-term care facility from a local hospital. The patient is being treated for psoriasis. The psoriasis does not appear to be responding to the treatment. 48 hours later, the infection preventionist receives a report that a certified nursing assistant has developed an itchy rash. The patient's physician visits and determines that the patient has crusted scabies, not psoriasis. Another name for crusted scabies is A. American scabies, B. Norwegian scabies, C. Canadian scabies, or D. English scabies. The answer is B. Norwegian scabies. Crusted scabies is just another name for Norwegian scabies. It's a severe, highly contagious form with a huge number of mites. This is important because it spreads easily, not just skin to skin, but also through contaminated surfaces. Crusted scabies is a severe form of scabies that can occur in individuals who may be immunocompromised, elderly, disabled, or debilitated. It's also called Norwegian scabies. In immunodeficient individuals and in senile patients, infestation often appears as a generalized dermatitis, more widely distributed than the boroughs, with extensive scaling and sometimes vasculations and crusting, Norwegian or crusted scabies. The usual severe itching may be reduced or absent. What you see here is classic scabies. Symptoms include intense itching that worsens at night and a pimple-like rash with tiny raised, wavy burrow lines on the skin. Symptoms typically appear 2 to 6 weeks after the first time exposure or within days during a reinfection. Skin distribution usually involves webs of the finger, axilla, areola, and genitalia. Question 2. Guidelines for transporting specimens include 1. Transport within 2 hours of collecting a specimen. 2. Transport in leak-proof specimen containers and sealable leak-proof bags. 3. Transport specimen in a syringe used to collect it. 4. Refrigerate all specimens prior to transport. The answer is C. Accurate laboratory results begin with proper specimen handling. Once a specimen is collected, it must be transported promptly, ideally within 2 hours. Any delay can compromise the test results. Exposure to temperature extremes can damage or kill microorganisms, leading to inaccurate findings. For this reason, certain specimens should never be refrigerated. These include spinal fluid, genital specimens, eye specimens, internal ear specimens. These sample types may contain microorganisms that are very sensitive to cold temperatures. Specimens must be placed in containers specifically designed to maintain the survival of the suspected microorganism. All materials should be properly labeled, packaged, and protected throughout transport. To ensure safety and prevent contamination, always use a leak-proof specimen container. These should be placed inside sealable, leak-proof bags before transport. This protects both the specimen and anyone handling it. One important rule is to never transport syringes with needles attached. This reduces risk of needle stick injuries and ensures compliance with safety standards. By following these guidelines, we support patient safety, ensure accurate results, and contribute to effective infection prevention. Question 3. Which is true about a tuberculin skin test, or TST? A. positive TST indicates active tuberculosis or TB infection. B, negative TST rules out active TB infection. C, positive TST indicates past exposure to TB. Or D, negative TST indicates past exposure to TB. The answer is C. Positive TST indicates past exposure to TB. The TST involves injecting a purified protein derivative, or PPD, which is derived from a mycobacterial cell wall. The principle behind the test is that individuals who have been infected with mycobacterial tuberculosis will develop a delayed type hypersensitivity reaction to this injected protein. It is important to understand that TST is strictly a screening tool. Its purpose is to identify people who have latent TB infection or LTBI. The TST cannot be used to confirm or rule out active tuberculosis disease. It's important to understand TB skin test interpretation. Interpretation of a TB skin test depends on two factors. One, measurement of the induration in millimeters, and two, the person's risk of being infected with TB and of progression to disease in the infected. The CDC offers a detailed explanation of the interpretation of the TB skin test. The 3 cut points below should be used to determine whether the skin test reaction is positive. A person with positive reaction should be referred for a medical evaluation for latent TB infection and appropriate follow-up and treatment if necessary. A measurement of 0 millimeters or a measurement below the defined cut point for each category is considered negative. Again, it's important to understand how we measure the TB skin test. We're looking for induration or swelling, not the erythema or redness. Here's an example of how to measure the induration and what a positive may look like. Question 4. The optimal time to collect a sputum specimen for acid-fast bacilli, AFB, testing to rule out TB would be A, first thing in the morning, B, after a respiratory treatment, C, prior to the patient going to bed, or D, prior to a respiratory treatment. The answer is A, first thing in the morning. The CDC and APIC recommend that at least one of the 3 required sputum specimens be an early morning sample. Early morning is the optimal time for TB sputum collection because it ensures the highest concentration of bacteria as secretions accumulate overnight, specifically increasing diagnostic yield. Question 5. A hospital has hired a new manager of the microbiology section of the laboratory. During initial discussion with the manager about the infection prevention and control program, the IP stresses the importance of collaboration between the departments in reducing healthcare-associated infections. Of the choices below, which activity will best meet the goal? A microbiology staff's compliance with the annual flu vaccination program and tuberculosis skin testing. B, the microbiology staff's participation in the periodic infection prevention education sessions for hospital staff. C, microbiology's prompt notification to the infection prevention and control department of any organism's unusual resistance pattern. Or D, the microbiology manager's attendance at local, state, and/or national infection prevention and control education conferences. A key way to answer this question is make friends with your lab team members. The relationship between IP and the lab is integral to this work. The most important collaboration is communication. The lab must quickly report unusual resistant patterns. This supports surveillance and infection prevention, which means our answer is C. The active involvement and cooperation of the microbiology laboratory is critical to the functioning of the infection control program, particularly in surveillance and the use of laboratory services for epidemiological purposes. Question 6. The primary immune response after exposure to a communicable disease pathogen or vaccine is a production of A, immunoglobulin G or IgG, B, immunoglobulin M or IgM, C, immunoglobulin A or IgA, or D, immunoglobulin C, IgC. There are 5 immunoglobulin classes, isotypes, of antibody molecules found in serum: IgG, IgM, IgA, IgE, and IgD. IgA, or immunoglobulin A, is the principal antibody in secretions that bathe mucosal surfaces, first line of defense. IgD, immunoglobulin D, expressed in the plasma membranes of immature B lymphocytes. IgE, or immunoglobulin E, when your immune system overreacts to an allergen and/or parasite, it produces IgE. IgG, immunoglobulin G, found in all body fluids, protects against bacterial and viral infections. Think long-term antibody. And IgM, immunoglobulin M, first antibody to be made by the body to fight a new infection. The answer is B, immunoglobulin M. During the primary immune response that occurs after a communicable disease pathogen or vaccine is encountered, the class of antibody that is produced first is IgM. IgG antibodies develop a few weeks later. IgG antibodies are a good indication of convalescence period and generally mark the establishment of long-term immunity to the pathogen. When are IgM antibodies to hepatitis A virus or HAV detectable in the blood? A, 30 days after exposure. B, 5 to 10 days after exposure. C, 1 to 4 days after exposure. Or D, 15 to 20 days after exposure. The answer is B, 5 to 10 days after exposure. Hepatitis A is an acute liver disease. Clinical features of acute hepatitis are not specific for HAV infection, so serological diagnosis is necessary. IgM antibodies to HAV, which are used to diagnose acute HAV infection, are detectable within 3 weeks of exposure and are present at the onset of jaundice. Titer declines over 4 to 6 weeks, and antibodies are usually not detectable after 6 to 12 months. IgG anti-HAV is also detectable at onset of jaundice and remains positive lifelong, indicating immunity to HAV. Most people get hepatitis A by person-to-person contact or fecal oral with someone who has the infection or through eating or drinking food or water contaminated by an infected person. People can also get hepatitis A through sex or by close contact with an infected person, such as a household member. People who are at higher risk for hepatitis A include people who use injection or non-injection drugs, who are homeless, who are or were recently incarcerated, men who have sex with men, people who are traveling to countries where hepatitis A is common. To note, people with chronic liver disease such as cirrhosis or hepatitis B or C are at an increased risk of complications if infected with hepatitis A. People may also contract hepatitis A after eating sewage-contaminated shellfish, such as cockles, oysters, or clams that have not been cooked thoroughly. Question 8. The incubation period for pertussis in immunocompetent persons is usually A, 7 to 10 days, B, 3 to 5 days, C, 1 to 2 days, or D, 2 to 4 days. The answer is A, 7 to 10 days. Pertussis, also known as whooping cough, is a highly communicable acute infectious respiratory disease caused by Bordetella pertussis. The incubation period of pertussis in immunocompetent patients is usually 7 to 10 days, with a range of 6 to 21 days. In rare cases, the incubation period may be as long as 42 days. Remind everyone of the importance of getting vaccinated. Pertussis vaccination prevents severe whooping cough, reduces infant hospitalization, and stops disease spread. Immunizing caregivers and healthcare workers protect vulnerable newborns who are too young to be vaccinated. Question 9. A patient who was hospitalized for 2 days calls 3 days after discharge complaining that he has developed healthcare-associated scabies due to his recent inpatient stay. The IP knows that his scabies infection is not healthcare associated because A, scabies is only transmitted through contaminated linens, and the IP confirmed that all the linen the patient came into contact with had been properly laundered. B, the incubation period of scabies is longer than 5 days. C, the incubation period for scabies is shorter than 3 days. Or D, scabies is only transmitted through direct contact and none of the healthcare personnel who cared for the patient are infected. The answer is B. The incubation period for scabies is longer than 5 days. The incubation period for scabies may be as short as 10 days, but typically between 4 to 6 weeks. Therefore, the patient could not have acquired scabies during the hospital stay because, based on the incubation period, he would need to have been exposed at least 5 days before he was admitted. Question 10. A nurse is concerned that a patient in the neurology ward has a prion disease after receiving a lab report stating that the patient had a positive nucleic acid test for John Cunningham virus, JCV, in the cerebral spinal fluid. What is the best response to give the nurse? A. The test is positive for CJD, which is a prion disease. B. The test is positive for Campylobacter jejuni, which is not a prion disease. C. The test is positive for JCV, a papillomavirus, which is not a prion disease. Or D. The test is positive for JCV, a papillomavirus, which is a prion disease. The answer is C. The test is positive for JCV, a papillomavirus, which is not a prion disease. JCV is a polyomavirus that can cause a demyelinating disease called progressive multifocal leukoencephalopathy in immunocompromised individuals. Because of the name and some presenting symptoms, JCV is sometimes confused for CJD, which is a prion disease. Question 11. An IP is conducting an educational session to help the nursing staff understand infectious disease transmission. She explains that the initial element in virulence is the ability of an organism to survive in the external environment during transit between hosts. What is the second element of virulence? A. Secretion of enzymes that enhance spread through tissues. B. A mechanism of transmission to a new host. C. Invasion and dissemination in a host. Or D. Avoidance of the host resistance. To kind of help answer this question, you have to understand infectious disease transmission, also known as the chain of infection. So, a model that explains how an infectious disease spreads from one person to another person through 6 key links is shown in front of you. The infectious agent, the reservoir, portal of exit, alongside the mode of transmission, portal of entry, and susceptible host. The infectious agent is the germ, like a virus, bacterium, fungus, or parasite that causes the illness. The reservoir is the place where the germ lives, grows, multiplies, such as a human, animal, or surface. Your portal of exit is how the germs leave the reservoir, such as through the nose, sneezing, or cuts. Mode of transmission is how that germ travels to a new person through direct contact, the air, or dirty objects. The portal of entry is how the germ gets into a new body, such as through the mouth, nose, or broken skin. And then you have the susceptible host, a person who is weak or lacks immunity, making it easy for infection. That leads us to our answer B, a mechanism for transmission to a new host. The second element in virulence is a mechanism for transmission to a new host. For example, insect vectors may transmit pathogens by injecting material from salivary glands or defecation into sites of penetration of host skin. Some viruses can survive and be transmitted to hands from environmental surfaces such as bed rails. Some bacteria possess mechanisms of mobility. When a microorganism reaches a favorable site for inducing disease, it must adhere to the structure that it will infect in order to survive. Question 12. The management of an infected surgical site includes the following foundation principles. 1. Open and drain incision. 2. Debride fibrous debris and necrotic soft tissue. 3. Replace hardware. 4. Implement antimicrobial management as needed. 5. Manage the open wound. The answer is D. Each infected wound has a unique patient profile, unique characteristics of the operation, and unique bacteriological features. The diversity of variables in the infected surgical site has resulted in a diverse number of operations that are employed in management. The foundation principles in the management of the infected surgical site are 1. Open and drain incision. 2. debride fibrinous debris and necrotic soft tissue. 3. Remove foreign bodies. 4. Implement antimicrobial management as needed. And 5. Manage the open wound. Question 13. During annual TST, an employee's test result was read at 10 millimeter in duration. The employee's last TST was negative. The initial result indicates A, a positive test, B, false positive, C, negative test, or D, false negative. The answer is A, a positive test. A positive test is determined by the number of millimeters of induration, not erythema, caused by the reaction to the tuberculin. Different cut points are used depending on the likelihood of the individual having TB infection and the likelihood that the infection, if present, will progress to active TB. A 10 millimeter reaction in a healthcare worker is considered a positive test. All healthcare personnel with a positive baseline TST results should be referred for medical and diagnostic evaluation. Additional skin testing is not needed. Question 14. A microbe that can grow in the absence of oxygen but is also able to utilize oxygen for growth is A, an aerobe, B, obligate anaerobe, C, facultative anaerobe, or D, microaerophilic aerobe. The answer is C, facultative anaerobe. Facultative anaerobe will utilize oxygen if it is present but are still able to grow in the absence of oxygen. Microbes that must have oxygen to grow are called aerobes, whereas microbes that only grow in the absence of oxygen are obligate anaerobes. Microaerophilic bacteria need a small amount of oxygen for their growth. Question 15. Western blot testing for human immunodeficiency virus, or HIV, is used to detect A, HIV DNA in a serum sample, B, HIV RNA in a serum sample, C, HIV antibodies in a serum sample, or D, HIV proteins in a serum sample. The answer is C, HIV antibodies in a serum sample. The Western blot is a confirmatory test that is performed on all samples that have tested positive for HIV on enzyme immunoabsorbent assay, or EIA. HIV proteins are run through a gel matrix and then transferred to a thin membrane. The membrane is incubated with a serum sample, washed, and then incubated with a secondary antibody. If antibodies to the HIV proteins that were run through the gel are present in the serum sample, they will complex with those proteins and will not be washed away. A secondary antibody with a fluorescent tag will then bind to the HIV antibody protein complex, and this allows the antibody protein complexes to be visualized. An infection preventionist is reviewing the cerebrospinal fluid results from a patient admitted the previous night. The CSF is cloudy and has an elevated white blood cell count, markedly increased neutrophils, low glucose level, and elevated protein concentration. What type of meningitis should she suspect? A, bacterial, B, viral, C, fungal, or D, aseptic? The answer is A, bacterial. The diagnosis of bacterial meningitis rests on the examination of the CSF. The CSF appearance is typically cloudy or turbid depending on the presence of significant concentrations of white blood cells, red blood cells, bacteria, and/or protein. In untreated bacterial meningitis, the white blood cell count is elevated. Bacterial meningitis usually leads to a neutrophil predominance in CSF, typically between 80 to 95%. The CSF glucose concentration is less than 40 milligrams per deciliter in approximately 50 to 60% of patients. The CSF protein concentration is elevated in virtually all patients with bacterial meningitis. We provided you a great table for CSF interpretation. If you want to hit pause here so that you can review, memorize, it'll help you through any questions on the test that are like this previous one, but also help you through your career as you decipher some of your labs you're going to be seeing. Question 17. Which of the following statements about influenza is false? Influenza is primarily spread between individuals via respiratory secretions or droplets. B. Viral shedding starts 48 to 72 hours after infection and typically 48 hours before the onset of symptoms. C. Viral shedding normally persists for less than 5 days, but can be longer in children and immunocompromised patients. Or D. The typical influenza symptomology is not always predictive of influenza in elderly and immunocompromised patients. The answer is B. Viral shedding starts at 48 to 72 hours after infection and typically 48 hours before onset of symptoms is false. Influenza viruses are spread from person to person primarily through large particle respiratory droplet transmission. Transmission via large particle droplets requires close contact between source and recipient because droplets do not remain suspended in the air and generally travel only a short distance, 3 to 6 feet, through the air. Contact and respiratory droplet contaminated surfaces is another possible source of transmission. The typical incubation period for influenza is 1 to 4 days, average 2 days. Adults shed viruses from the day before the symptoms begin through 5 to 10 days after illness onset. However, the amount of virus shed and presumably infectivity usually decreases rapidly by 3 to 5 days after onset. Young children also might shed virus several days before illness onset of symptoms. Severely immunocompromised persons can shed virus for weeks or months. Is it the cold or is it the flu? Let's see. For colds, the onset is gradual, over a day or more. Fever is low or none. Severity is mild to moderate, and symptoms sore, scratchy throat, then a runny or stuffed nose, sneezing, and finally a cough. Versus the flu, the onset is sudden, within a day or sometimes even hours. High temps are common, often over 100 degrees Fahrenheit. Severity is more severe, and as far as symptoms, chills, dry cough, fever, headache, severe muscle aches, stuffy nose, sore throat, extreme fatigue, and weakness are to be expected. In keeping with the influenza theme, question 18. Which of the following statements is false regarding influenza viruses? A. They are divided into 3 categories, A, B, and C. B. Influenza A strains have been the predominant cause of worldwide epidemics or pandemics. C. Influenza A and B strains have been named according to the city or state and year of their initial isolation. Or D. Influenza B strains have not been associated with large epidemics. The answer is D. Influenza B strains have not been associated with large epidemics. Influenza viruses are divided into 3 categories designated A, B, and C. All 3 contain negative sense segmented single-stranded RNA molecules. Influenza A viruses are the most common clinical isolates, and they are subdivided by differences in 2 surface proteins, hemagglutinin and neuraminidase. 3H and 2N antigenic subtypes account for virtually all human infections. The most prevalent influenza A strains in humans in the last 30 years have been H3N2 and H1N1. In recent years, influenza A and B strains have been named according to the city or state and year of their initial isolation. For example, A, Texas 3691, or B, Hong Kong 330 2001. Influenza A strains have been the predominant causes of worldwide epidemics or pandemics. Influenza B strains also cause epidemic disease, but the clinical illnesses tend to be milder than illnesses caused by influenza A. Influenza C strains are much less common, less than 1% of influenza infections, and they produce generally mild illness, usually like a common cold. Influenza C strains have not been associated with large epidemics. Question 19. Which factor is commonly associated with Clostridium difficile infections? A. Chemotherapeutic agents. B. ACE inhibitors. C. Prophylactic antibiotics or antibiotics to treat a primary bacterial infection. Or D. Antiviral medications to treat a primary viral infection. The answer is C. Prophylactic antibiotics or antibiotics to treat a primary bacterial infection. Clostridium difficile is a spore-forming gram-positive anaerobic bacillus that produces 2 exotoxins, toxin A and toxin B. It is a common cause of antibiotic-associated diarrhea. It accounts for 15 to 25% of all episodes of AAD. The risk for disease increases in a patient with antibiotic exposure, proton pump inhibitors, gastrointestinal surgery or manipulation, long length of stay in healthcare settings, a serious underlying illness, immunocompromising conditions, or advanced age. The CDC has some really great flyers for the infection preventionists in the healthcare setting. Remember that clean hands count when it comes to C. diff. Wear gloves and clean hands with soap and water. C. diff forms spores that are not killed by alcohol-based hand sanitizer. Question 20. The IP is reviewing the history of a patient who has been in the facility on a ventilator for 1 week. All of the following are risk factors for colonization and infection with multi-drug resistant pathogens except A. Antimicrobial therapy, B. Current hospitalization, C. Immunosuppressive state or therapy, D. Low frequency of antibiotic resistance in the facility. The answer is D, low frequency of antibiotic resistance in the facility. Pneumonia may be caused by a wide variety of pathogens. Multi-drug resistant organisms, or MDROs, are becoming more relevant as etiologic agents. Risk factors for colonization and infection with MDROs are as follows: antimicrobial therapy in the preceding 90 days, current hospitalization of 5 or more days, high frequency of antibiotic resistance in the community or in the specific hospital unit, presence of risk factors for healthcare-associated pneumonia, and/or immunosuppressive state or therapy. Keep in mind your ventilator bundle elements. Below are the components to help prevent VAPS: elevation of the head of bed at 45 degrees or greater, daily sedation, vacations, and assessment of readiness to extubate, daily oral care with chlorhexidine, proton pump inhibitors or H2 receptor antagonists, and anticoagulants or compression devices. Question 21. The current community-acquired pneumonia, or CAP, national quality measures used in the United States include all of the following except A. Antibiotic timing within 6 hours of arrival, B. Antibiotic selection, C. Blood cultures performed in the emergency department before antibiotics are administered, or D. Ensure that all patients are screened for pneumococcal vaccination. The answer is D. Ensure that all patients are screened for pneumococcal vaccination. The core quality measures are a set of standards defined by the Joint Commission and the Center for Medicare and Medicaid Services to create core measures for disease management for CAP. The measures create consistent evidence-based practice in facilities caring for CAP patients. The CMS measures adherence to the measures and publishes the results. The core measures for CAP include oxygen assessment within 24 hours before or after arrival at the hospital, patients over 65 screened for pneumococcal vaccination and administration before discharge if necessary, blood cultures performed in the emergency department before antibiotics are administered, antibiotic timing within 6 hours of arrival, antibiotic selection, adult smoking cessation advice and counseling provided, and influenza vaccination. Question 22. Measures that can be practiced for prevention of aspiration include all the following except A. Antibiotic prophylaxis, B. Oropharyngeal cleaning and decontamination with an aseptic agent like chlorhexidine, C. Orotracheal intubation unless contraindicated rather than nasotracheal intubation, D. The head of bed elevated at an angle of 30 to 45 degrees. The answer is A, antibiotic prophylaxis. The following precautions should be practiced for prevention of aspiration. Use of non-invasive ventilation when possible to reduce the need for and duration of endotracheal intubation. This refers to all modalities that assist ventilation without the use of an endotracheal tube. Perform orotracheal intubation unless contraindicated. Nasotracheal intubation has been associated with higher incidence of nosocomial sinusitis, making the patient more prone to the development of pneumonia through aspiration of infected secretions. The head of the bed should be elevated at an angle of 30 to 45 degrees. Oropharyngeal cleaning and decontamination should be performed with an aseptic agent like chlorhexidine. Stress ulcer prophylaxis may be provided with proton pump inhibitors, histamine 2 receptor antagonists, or sucralfate. Question 23. All of the following are descriptions of patients with immunocompromised status except A. HIV with CD4 count less than 200, B. Leukemia or lymphoma, C. Neutropenia with the absolute neutrophil count less than 500, D. 1 year post bone marrow transplant. The answer is D. 1 year post bone marrow transplant. Patients with immunocompromised status include those with the following: neutropenia, absolute neutrophil count less than 500, leukemia or lymphoma, HIV with CD4 count less than 200, splenectomy, early post-transplant, on cytotoxic chemotherapy, on high-dose steroid therapy. The paroxysmal stage of pertussis usually lasts A. 1 to 6 weeks, B. 11 to 15 weeks, C. 15 to 20 weeks, or D. 6 to 21 weeks. The answer is A. 1 to 6 weeks. Pertussis or whooping cough is a highly communicable acute infectious respiratory disease caused by Bordetella pertussis. The onset of pertussis, known as the catarrhal stage, begins with coryza or runny nose, sneezing, low-grade fever, a mild occasional cough that gradually becomes more severe. The cough that began during the catarrhal stage progresses steadily, becoming paroxysmal, numerous rapid coughs. It is during the second paroxysmal stage that the diagnosis of pertussis is usually suspected. The classic symptoms of pertussis include whoop, vomiting, apnea, and cyanosis immediately after paroxysm of coughing. Infants younger than 6 months may have an atypical presentation with a short catarrhal stage, gagging and gasping, or apnea as prominent early manifestations. The whoop may be absent. The paroxysmal stage usually lasts 1 to 6 weeks but may persist as long as 10 weeks. And our last question for session 1, question 25. Which of the following is not an effect of malnutrition on the body's immune system? A. Intestinal bacteria may be altered. B. Tissue integrity is impaired. C. Mucosal secretions are decreased. Or D. Urine may be colonized with bacteria. The answer is D. Urine may be colonized with bacteria. Malnutrition affects the body's immune system by altering the intestinal bacteria, impairing the integrity of tissues, and decreasing mucosal secretions. Tissue integrity is impaired. Decreased intestinal epithelium, mucosal lining, atrophy of the gut's associated lymphoid tissue, which is part of the immunologic barrier of the intestine. Respiratory tract cilia are decreased, mucosal secretions are reduced, intestinal bacteria may be altered, colonization in the normally sterile upper small bowel may occur, and acid secretions may be decreased in the stomach.